So what I started this out with is a quote that many people threw at us when in year 2000, my partners and I at Texas Spec said, hey, we're going to start an FDA study with lumbar disc replacement. And a lot of people said, what are you doing that for? You know, fusion works fine. So we now have the ability, 22 years later, to actually look back at some of the more specific objections people had and discuss them because we have the data. But I just wanted to let you know, again, this has been such a rare opportunity for me in my career because it's just happenstance that you're in the right place at the right time. You have the right training and the right networking. But the second half of my career has had its arms around this technology from the very beginning when the disc was brought over from Europe, to the design of the FDA studies, to the implementation of the FDA studies, tracking patients, and then data gathering and publication and presentation and arguing with insurance companies. So it was sort of come full circle. And it's all happened in the lifespan of my career. And that's unusual, unless you happen to be practicing at the time of Lister and anesthesia. You just those things usually don't happen when you're actually working with them. So it's been terrific for me and for many of us in the room. It's been the highlight of our career. So the surgical treatment for low back pain really started to undergo scientific scrutiny as a result of these FDA PMA studies. Before that, we really didn't have a leg to stand on scientifically to justify doing fusions for people who had incapacitating back pain. But because these lumbar artificial discs were considered class 3 devices, which is novel technology, something that cannot be compared to a device that had been previously on the market, the FDA now required multi-center prospective randomized control trials comparing the artificial discs to fusions, which had been standard of care for so many years, and following them in a scientific manner. So for the first time, these patient populations were selected by carefully identified inclusion and exclusion criteria. A box was drawn saying, find us 300 of these patients. So to the 17 centers and 35 surgeons, their task was, as they saw patients in their office, if they thought they met the criteria, they would ask them if they'd be interested in enrolling, have a clinical research coordinator come in and really dig in a little bit deeper and find out, this one's got lupus and you can't get in, So they further refined it, but then they found those 300 patients who met criteria, who could be enrolled in the study, externally randomized, operated on, then followed with defined endpoints for 2 years, 5 years, and even 7 years. And the neat thing was we're collecting the same data on the fusion control patients. So here we had, the fusion, which was kind of accepted as a community standard, but had never really been well studied. And we got the same data points on those patients. So this was a wonderful opportunity to do good science. And, we're surgeons. We're kind of scientists, but not really. We'd rather be in the OR than we would be, filling out forms and signing off on procedures. But they made us do this. And now we can kind of reap the rewards because now the flowers have bloomed and all that work comes in. So, I'm going to show you forest plots and graphs and spreadsheets, and other people have done it at presentations. But you got to remember where all those data points come from. We kind of lose sight of that. You see a beautiful forest, you forget about, all the roots and trees that are there. It all comes from individual patient contacts over time. So these are every week. As the PI at our site, I had to sign off on every single patient contact, and each case report form had 20 pages, each one requiring the patient to initial and sign and the PI to initial and sign, because I was the one that was going to go to jail if there was a problem. So, what I told them to do is just leave these on my desk chair, because if you put them on my desk, I'm just going to have a mountain that gets bigger and bigger, but put them on my desk chair, so I have to address them over the weekend. So this was, just week after week after week. These are individual patient data point contacts that not just I was doing, but every site was doing, and in every single study that we're going to show you at every single patient visit. So that's where the data comes from. So this is collected, again, by clinicians. It's in the trenches. It's not done by people sitting at computers all day. This is done by us. So the clinical data is very robust. There are 10 to 12 data points for every single one of the patients enrolled in the study over a 5 to 7 year period. And it's the exact same data that's collected from each patient at each visit. So they fill everything out and get their x-rays done preoperatively. Then they came back at 6 weeks, at 3, 6, 12, 18, and 24 months. That data was sent to the FDA. And if the disc was commercialized, then they came back annually to 5 years for the ProDisc study and 7 years for the ActiveL study. And this included in the clinical evaluation the patients filling out ODIs and SF-36, and they filled out the exact same form every single time. They filled out a VAS for pain and VAS for satisfaction. Their physical exam was pretty limited. It was really just a basic neuro exam for straight leg raise, motor sensor, and reflex. And then they had x-rays, which were all digitized at every visit, standard films digitized, sent down to medical metrics. So you can see the only opportunity here for the surgeon to be involved was in the neuro exam. It's really the only surgeon input. Everything else was either patient-driven data or radiographic data. So it really, for once, we had studies that would basically eliminate a significant opportunity for surgeon bias, because that's always been the criticism of any kind of study, particularly retrospective one, but any surgeon-involved study. And the radiologists and medical metrics had developed algorithms for measuring range of motion and also for determining fusion for fusion patients. So prior to year 2000, that's from PubMed, the number of articles that had been published on arthroplasty were pretty small. You can see just an occasional paper every few years. But starting in 2000 and 2001, 2002, 2003, as the study was evolving, we started giving presentations about our single site 6-month data and pooled data from 2 sites at 1 year and 2 years. So presentations and papers started building, and this was an evolving science. And at the beginning, we didn't really know whether this was going to be a good thing or a bad thing, but what we did know is we were studying it in a scientific way. We had layers of protection because the FDA was providing oversight with audits. We had independent people coming in to audit the forms and make sure that there was no issues with either patient care or with patient reporting. So there was some comfort level, but there was still some trepidation that, maybe this won't turn out to be a good thing, but fortunately we did okay. And at the end of the day, why do I recommend arthroplasty to patients now? Because now we've got the data. Now it's not just, boy, this looks like a good thing, or I think it's going to be better than fusion, but we really know what's going on. And, over the next 15 minutes or so, I'm going to show you the cumulative 20 to 22 year data, and better than anything else we use. Total hip replacements, total knees, plates, screws, rods, even non-orthopedic things like intraocular lenses. Nothing has gone through this level of scrutiny, and yet those devices are put in by the thousands or tens of thousands on a regular basis in patients. So, this represents an unusual opportunity to be able to look back at the early objections and now counter them with really good long-term data. So the big objections, the big one was, you guys are going to operate on everybody. Everybody with low back pain is going to get this. You're going to stretch indications. You're going to have trouble. Threaded fusion cages had just gone through IDE studies. And there was a lot of hype and a lot of promotion. It turned out they were not so great, that there was small contact area, there were non-unions, a kyphotic collapse, malalignment post-op. So it didn't turn out to be a panacea, and they said, this is going to be just like that. You guys are going to screw this up. They said you're going to have higher perioperative complications because you have to do this through a retroperitoneal approach. You got to be directly anterior. You got to move the vessels over. It's not like an ALIF where you can kind of sneak grafts in. You have to be very precise, and you're going to regret the day you started this. People said you're going to have a lot of revisions. This is new technology. These are moving parts. They're going to break. They're going to come out, and you're going to have patients losing life and limb. And the last thing they said is, what are you screwing around for? Fusions are fine. Fusions work well in everybody's hands, and just look at all the literature, of which there was not very good literature. But these were the four things that when Scott would stand in front of people, or I would stand in front of people, or Dr. Chapman would stand in front of people, these are, real life objections that people had. So it is 22 years later, and we can now look back at that and kind of, answer each one of these. As far as indications, low back pain, certainly in the year 2000 was, and to many, unfortunately, it still is considered kind of a wastebasket diagnosis. Somebody, they got back pain, and we'll do a 4-level fusion, or we'll do nothing, keep them on narcotics, but people didn't have the tools or the interest really to have a diagnostic algorithm. That was one of the things that attracted me to TBI. They did have a diagnostic algorithm for working people up, so that at the end of the day, when you selected your patients, you had a pretty good chance that they would have a good outcome, because you've eliminated the people beforehand who are not going to have a good outcome. Older literature on fusions, as I mentioned, was not good. It was mostly a retrospective analysis from a single institution where they pooled patients who could be a 19-year-old with a lytic spondy, along with a 30-year-old with a recurrent disc herniation, along with an 80-year-old with degenerative scoliosis. And they all went into the fusion box, and guess what? The results were mixed. Not great, not terrible, but not generally good, because your patient population was so heterogeneous. The nice thing about these IDE studies is that box was defined. Show us patients between 20 and 60 who have clear single-level disease, who have failed 6 months of conservative treatment, who have this much ODI, who have this much VAS pain, and prove to us that it's single-level disease, and then randomize them externally, not by the surgeons who want to pick the athletes for their new technology, but an external group, and then follow them all exactly the same for 2 to 5 to 7 years. Unique. So the numbers of lumbar fusion since the year 2000 really have gone up. Nationally, regionally, fusions are increased, and these are largely attributed to an aging population that doesn't want to age, that wants to stay active. The fact that there are more trained spine surgeons around these days than there used to be, and we have better devices and better technologies, and complication rates are less, fusion rates are more. But if you look at the increased curve for fusion in general and the increased curve for arthroplasty, it doesn't parallel it at all. The increased curve for lumbar disc replacement has stayed much, much lower. It has never been documented that there is that explosion of you're operating on everybody, because the people who were pointing the fingers and making those claims, particularly the government and the insurance industry, have never once raised a hand and said, you're doing too many. And part of the reason is they've kept a lid on authorizations and approvals, and stretched indications have really not been an issue. We just haven't seen that explosion. The major deterrents to increased volume in lumbar disc replacement have really been, disappointingly, I think, surgeon acceptance because of the data that I'll show you. Insurance approval, which is incredibly frustrating because there's sort of nobody overseeing the insurance industry when they're pushing patient care to the side. And also lower physician reimbursement. The sad fact is that for an operation that's more technically and intellectually demanding, the reimbursement both for cervical and lumbar is less than it is for a fusion, which is less intellectually and technically demanding. It's not fair anyway. But here's just a look at the insurance penetration curve for lumbar disc replacement. And you can see this, it starts at 2011. So discs had already been FDA approved about 5 years, and it was about 25%. And then Aetna dropped approval after having covered Charité disc particularly, but ProDisc also for 6 years. They dropped the approval, so you can see it dropped down to a low of 13%, and it's just slowly crept up. And it's currently at about 83 to 85%, still lacking Aetna, actually, as the major insurer. But now about 80% of insured Americans have a policy that, at least on paper, allows them the opportunity to get at least a single-level disc replacement. To this date, still no insurance carrier has given approval formally for two-level disc replacement, although Scott tells me he thinks a couple of carriers have just recently changed that policy. So stretched indications, one of the biggest fears in year 2000, it just hasn't come about. And we can look back on that now and say, we haven't seen that. That concern can come off the table. As far as higher perioperative complications, in an FDA study, all this stuff is scrutinized really carefully. All the intraoperative and perioperative issues have to be reported to the FDA, ultimately become in the public domain. So we haven't seen that. We do know by looking at the data between the control group, the fusion patients, and the arthroplasty patients in all the FDA studies, that the perioperative morbidity of disc replacement is always less than that of fusion controls, and that device-related SAEs, one of the other fears because this is novel technology and moving devices, has also been never shown to be any worse than it is with fusion devices. Longer-term concerns for those who say, well, perioperative morbidity may be expressed later down the line, there's post-market surveillance. The FDA requires post-market surveillance for 5 years out for the ProDisc, for 7 years out for the ActiveL, and that some of that surveillance was actually published by Chris Radcliffe and other authors last year. So those concerns have not been substantiated either. The revisions, the ones where, oh, you guys are crazy, these are going to cost patients life and limb. We have data. The anterior revision rate, the one we worry about, not the other stuff, not the patient who may need a laminotomy, a patient who may need epidural steroid injections, or even the patient who may need a stimulator. Those are not life-threatening revision surgery. It's the anterior lumbar revision surgery. So here are 3 slices of that pie. In the first 1,000 cases that were done after ProDisc approval, there were 3 patients who required a revision anterior approach, all successfully. In the 8-year period when 1,300 surgeons were trained on ProDisc between 2006 and 2013, the anterior revision rate was just a shade under 1%. And I think in the strongest one is the registry data from TBI, where we've tracked every patient since Scott Blumenthal put the first Charité in year 2000. We've tracked every single one of those patients continuously. And when we looked at our first 1,707 patients over that 17 years, there were 17 cases, which is 1%. Most of those are L5S1. All of them are taken very seriously, but all of those patients were successfully revised. And this is a really low number. We wish it was 0. But it's a much lower number than our revision rates for common things like a lumbar laminectomy, which is between 5 and 15%, so to put it in perspective. So revisions have not been shown to be a big issue either. So that brings us to outcomes. Are we looking for a triumph of technology over reason? Is there really some rationale for doing this, or are fusions good enough? Well, it turns out that the outcomes are really where arthroplasty has shined. The seminal papers were the 2-year data collections, which were submitted to FDA and then published in spine for both ProDisc under Scott's name and, the Charité under Scott's name, ProDisc under my name. These typically show a hockey-shaped recovery curve. These are VAS pain scores. And the thing to remember is the pre-op number represents patients who, at least in the ProDisc study, had failed 9 months of aggressive conservative care. So these are patients that had all the physical therapy, the injections, the narcotics, all the stuff that you do, and yet they were hovering at ODIs of 63 on average, and you only needed a 40 to get into the study. So they were 50% more impaired. And what happened to them at their first post-op visit, they had dropped almost 50% and maintained that drop for 2 years, and we've continued that data curve, and I'll show you 5 and 10-year data that shows that stays absolutely flat. And the interesting thing is, so do the fusion patients. So this gave us finally some evidence that if you select your patients right, a fusion is good. It turns out a disc replacement's better, because all the data points show that the patients did a little bit better there, and there are some other reasons why the arthroplasties were better. The nice thing is we were able to continue following these patients. Rick Geyer followed the Charité patients out to 5 years, found that there was no tail up, that there was no regression, and that ODI and VAS improvements were maintained between years 2 and 5. Range of motion was maintained, and the arthroplasty patients had a better return to work than the fusion patients. Rick Dellenroder and I published the 5-year follow-up of all the ProDisc patients at all the sites with 82% follow-up, showing the same thing, that curve stayed flat, that the 50% recovery in both ODI and VAS that happened right after surgery was maintained out now for 5 years. And while we were doing that, the ActiveL had started a study, and that was ActiveL is a disc versus disc study. So because ProDisc and Charité were already FDA approved, they could use them as a control rather than fusion. And Rolando Garcia published the 2-year data for ActiveL, and Jim, you followed it up with 5-year data. So these curves are actually 3 discs superimposed. These are showing longer-term data from different sites, different patients, different surgeons with ProDisc and Charité in addition to ActiveL, and we keep seeing that same hockey stick, immediate and significant improvement on patients who were stalled on maximum conservative care, and now they're maintained for 5 years on these curves. So we keep layering, data, really good data, prospectively collected, randomized data from different places, all showing the same thing. As I mentioned, Chris Radcliffe published 7-year outcomes follow-up for ActiveL patients, and here he showed how that hockey stick continues for actual data points, years 5, years 6, year 7, for both VAS and ODI. So really good durability of improvement is not just doing an operation to make somebody better for a year or two. These are sustained improvements. We've just submitted this paper for publication looking at predictive analytics based off that 7-year data for the adjacent segment degeneration, the radiographic, and adjacent segment disease, the need for intervention out to 10 years. And you can see from the line that the degeneration curve, the degeneration curve continues because these patients continue to get older. So by 10 years, the predictive analytics show that about 30% of patients will have radiographic degeneration, and that's what the general population shows. But the important thing is the other line, which is the disease line, showing that that is flat, and at 10 years, the statistics are predicting only 3% of patients are going to need another surgical intervention. And you compare that to what we tell our fusion patients, that at 10 years, 10 to 15% of them will probably need another surgical intervention. It's a significant difference. And we did reach out to about 75 of our early ProDisc patients with questionnaires asking them to fill out VAS and ODIs just to get a sense for a data point and whether it would be worthwhile to do a 10-year study. And you can see the 10-year data point is in line with all the data points before it, again, showing that consistency now out for 10 years. And just to mention that 2-level ProDisc has been FDA approved since January of 2020, so it's now 2+2.5 years since FDA approval for that. And again, disappointing, the insurance industry still dragging its feet on opening things up. So we have enough of this wonderful data that we can start putting that data together into meta-analyses and elevate this from level 1B data to level 1A data, meta-analysis being the best science we can do because we can bring much stronger statistical and analytic tools to bear when you have bigger data points. You can do things like this. This is a meta-analysis, a network meta-analysis I published, and it's really hard for a clinician, for me too as the author, to figure this out. But basically what it's saying is, for example, if you have a really well-done study that shows that ProDisc is better than a fusion, and you have another study that has randomized patients between a fusion and continued conservative care for another 2 years, then you can network those and show that when it comes to ODI, when it comes to back pain, when it comes to patient satisfaction, that the artificial disc is better than either the fusion or the conservative care. In other words, you can kind of meld those things together. This is kind of hard, again, for clinicians. This is a meta-analysis that clinicians understand. This meta-analysis that we did looked at worldwide literature for studies that were prospective randomized controlled trials of an artificial lumbar disc versus a fusion with a 5-year follow-up. So like every Prisma analysis starts by looking at 2,000 papers, winnows them all down, and it comes down to 4 papers. Matt Gornett had published the Maverick 5-year data versus fusion. Rick Geyer had published the Charité. We had published the ProDisc. And then there's a Scandinavian study that is modeled after an FDA study, but it's a Swedish study where they also used multiple centers in Sweden. They randomized their patients prospectively to receive either an artificial disc or a fusion, and they follow them at the same data points. So these are the 4 that we can pull out of the literature, and now you can use statistical analyses like risk ratios to answer a question: in which group at 5 years in these 4 huge multi-center studies is a patient less likely to need a reoperation? Reasonable question. And the answer is, in the arthroplasty group, not the fusion group, the risk ratio is 0.48. So it's almost 50% less risk that a patient at 5 years will need a reoperation if they randomly got a disc replacement 5 years ago than a fusion at a single level. You can ask a question: who's more likely to be successful in their ODI? In the US, that's a 15-point improvement from baseline. In Europe, it's a 25-point improvement. And it's the group who randomly got the disc replacement, not the fusion. Those people were more likely to have a benefit in their ODI. Reduction in back pain scores, which group is going to do better in back pain scores? Again, it's the arthroplasty group. And again, these are big numbers. This is all over the world, lots of surgeons, lots of patients. And the last one is not important to the FDA, but really important to us: in which group are the patients more satisfied? In which group are they happier? Would they do the operation again? Significantly more so in the arthroplasty group. And the heterogeneity is very high in these, where here's the heterogeneity, I-squared is 0%, meaning these are totally homogeneous patient populations as pertains to this question. So again, we keep building this huge mountain of data, all pointing in the same direction, and yet people still don't want to believe it or don't like to believe it. You can dial in 2 more studies because there are 2 disc versus disc studies that go to this compendium. It's the active L versus ProDisc and Charité disc versus disc study, and also Rick Iyer published the Kineflex data, which was a metal-on-metal disc replacement that did not go through the FDA because of the metal-on-metal issues that were happening with hips at the time, but still had strong data and a 5-year publication. So now there are 6 of these multi-center prospective randomized controlled trials of lumbar artificial discs that are in the public domain, all giving the same ultimate data analysis. So, begs the question of where do we have data like that for anything else that we use? We don't. We don't even scratch the surface. So one of the neatest papers that came out of this tried to answer the question of what is disc replacement going to help us with adjacent level disease? Is it really going to help decrease the need for more surgery? So we were able to use the lateral radiographs of all the patients that were down at Medical Metrics in digitized form, and it was a very simple study design. It was Rick Delamarter and I and one of our old TBI fellows. We published in the Journal of Neurosurgery, and we said to the radiologists down in Medical Metrics, here's a validated scoring system. Score the disc above where we're going to do intervention. So give it you guys give it the score that's intra and intra observer validated for radiologists. They love that scoring system. Tell us what the score is for the disc above pre-op and then 5 years later. So basically, now tell us what % of patients who randomized to a fusion were worse at their adjacent level. 28.6%. Okay, what % of patients who randomly got assigned an artificial disc were worse at the next level? 9.2%. And again, these numbers are coming right out of the radiologist database. This is not, we're not touching and massaging these numbers. That difference is 3 to 1, and that is highly statistically significant. So if you randomly got assigned to get an artificial disc, you had a less than 1/3 of a chance that 5 years later you're going to be worse. So we said to the radiologist, do one more slice, because there's a bunch of patients whose adjacent level was perfect. They had pure single level disease, so their score was 0. What happened to those patients 5 years later? Well, if they randomly got a fusion, now 23.8% of them had a 1 or a 2. They had gotten a bit worse. But of the patients who randomly got an artificial disc, only 6.7%. Turning that around, that means that 93% of patients who had a perfect disc above still have it 5 years later if they got an artificial disc. So again, this is better than 3-to-1 difference, also highly statistically significant. With a relatively simple study design, it's just that all the data was being collected, and we just figured out a good way to use it. The ActiveL people looked at this in a similar way, but that was a disc versus disc study, so they couldn't ask the radiologist to measure versus fusion. But they said to them, you have an algorithm for range of motion. Tell us what the effect of range of motion was on the scoring system 5 years later. And here it is. And it turns out that the percent of patients with adjacent segment degeneration radiographically were stiffer, that the more motion that the surgeon was able to put into that, for every degree of increased motion, there was a proportional decrease in the number of patients who had adjacent segment degeneration 5 years later, showing a protective effect of motion on the adjacent level. So, we've gotten a lot of information out of this evolutionary process, and it's, incredibly rewarding because we were there at the very beginning when people were saying you guys are nuts, to now being able to say, not so much. Now, look, we've all learned from this stuff. But arthroplasty devices, both cervical and lumbar, are really some of the most highly studied implants that we've ever put in the human body. That patients who show early improvement maintain that improvement. We've been able to demonstrate that. And one day maybe we'll be able to get FDA studies that are not 2 years minimum before reporting them. Maybe they can rely on 6-month or 1-year data and then post-market surveillance if they get comfortable with the fact that those curves stay very flat after 6 months. And that short-term data can be used as a predictor for later outcomes, that there doesn't seem to be a lot of variability. Once patients are doing well at their 6-week and 3-month and 6-month visits, they're going to do well no matter how long you wait. So, how much more do we need to show? I don't know. I think we've exceeded the bar of any device that's around. And, it's irritating when insurance companies and governments and other surgeons say to me, I don't really believe this. Or, a friend of mine is on faculty at a medical school in Long Island where they did a symposium on disc replacement. And the chairman got up at the end. He said, yeah, there may be a role for cervical disc replacement, but lumbar discs are totally unproven. This was like last year, with all this data published. And this is what a whole generation of residents sitting at his feet are hearing in 2021. It was pretty discouraging to hear that. But anyway, thanks for letting me share this with you, and hopefully share some of the enthusiasm. And thanks for this platform with Dr. Chapman. Thank you.
I know we want to go to the next lecture shortly, but I want to first of all recognize what you, Scott Rickguyer, have done is amazing. And you're a true pioneer, so it's an honor to have you here. I also want to point out is that in our state here, we have a very restrictive health technologies evaluation committee, which very unfavorably looks especially at new procedures, but any surgeries. And in public forum, and this is actually in written form, they actually testified that the data provided in the realm of disc replacements, thanks to you, is unprecedented, not just in the field of spine surgery, but in all of medicine. And that's a written statement by an extremely hostile forum. My second comment pertains to non-operative care. So I think when insurance bodies and government agencies fight back against procedures, what they don't adequately recognize is the lack of constructive, meaningful benefits of any non-operative care to recalcitrant, malignant, as we call it, back pain. Malignant not in terms of oncologic disease. Those patients who suffer from severe back pain do not get better over 5 years. Even Rick Deo and Sohail Mirza in this study from UW showed that there's no meaningful benefit for these patients. They go through sinus waves of whatever treatments. In terms of cost efficiency, so this is what it all boils down to. When you're a fiscally extremely prudent man who I highly respect in many regards, how can we show cost efficiency of disc replacements to make this unequivocally clear? Is there a convincing, I know you have the studies, but this is for me the last door to the Holy Grail to basically push that open. How can we cogently identify cost efficiency compared to non-operative care or fusion care?
Yeah, and there are a dozen papers that are published that show that. The direct costs alone, segment by segment, are always cheaper with an arthroplasty than they are with a fusion, unless you use structural autograft, so which nobody does anymore. That's the only construct for a lumbar fusion that's cheaper than a disc replacement, is hacking out a structural piece of the patient's crest. Once you go to anything commercial, and certainly any of the implants and biologics and fronts and backs, the costs can be 5x. So we've proven that direct costs, and half of those papers also went into the indirect costs, just as you've mentioned, Diane. So it's out there. It's just that there's no one holding the insurance industry's feet to the fire to make them look at that or make them admit that anything that has passed these criteria should be approved for insurance. Scott?
So putting aside all the other boundaries that we have, cost, anterior surgeon access, insurance, all that such, I think perhaps it's kind of a bigger picture than that. And I would say that it's perhaps an attack on surgical treatment of disc degeneration. So I'll bet that doc who said in front of 20 residents that there's no place for disc replacement, I'll bet he says, I don't fuse for back pain either. So, yes, we have barriers, and they change every few months to getting insurance approval. And, it's hard. I mean, if you're in a general spine practice, and we see it within TBI, some of our surgery schedulers have no idea how to get an artificial disc approved, so our partners just don't do it. The ones that work in the Center for Disc Replacement, we've trained them up, and they know the things that they have to do to get them approved. Let's pick Blue Cross in North Carolina. They won't approve lumbar disc replacement. Try getting a fusion approved for the same diagnosis. You can't. Cigna, you can get a disc replacement approved, but you can't get a fusion approved for discogenic low back pain. Now, what do surgeons do? They come up with, requires decompression such that instability will be created, and they get the fusions approved for essentially discogenic back pain anyway. But, you got a combination of moving target, specialized personnel that you need to get this stuff approved. And, as you mentioned, AIM, who's the third-party reviewer for a bunch of Blue Crosses, just changed their guidelines last month and didn't tell anybody until I had a denial for something that they approved 2 months ago. So we downloaded the new AIM guidelines. I'd recommend you do that. And they've changed. So, it's a game. And if you're not willing to fight it, I can understand why most surgeons say, I'm not even going to mess with lumbar disc replacement because it's just too hard. I can get my fusions approved most of the time.
Yeah, and you can also understand the insurance industry's reluctance to approve expensive surgery for back pain because it is and has been such a wastebasket diagnosis. But we've fixed that for them. We've defined the box of patients in which you can make the diagnosis, do this surgery, and predictably get them off narcotics, get them back to work, and restore them to humanity. So we've shown them all that stuff, and that's what the big frustration is. We've done their work for them. We're not asking them to approve, just a general diagnosis, but approve patients who fit the FDA criteria. That's not an unreasonable request. Well, let me move on. I think Dr.